All right, very good. Medication used in the office with a focus on buprenorphine. Disclosures, I don't have any of those. We have the presentation next week. So you guys are what we call Group A. Next week is Group B. You are more than welcome to join next week as well, because this lecture and the next lecture, they actually complement one another instead of like Group A gets the same thing that Group B gets. So this one and the next one kind of build off of each other. The next one is much more about how you go about doing an induction and some of the governing guidelines for managing buprenorphine in the state of Tennessee. So I think it would be beneficial to be at both if you have the time and the ability, because this one is much more about a kind of a broader look at the use of buprenorphine and the treatment of opioid use disorder using MAT. So scope of the problem, which is really kind of what this talk is about, is looking at sort of a bigger picture of approaching opioid use disorder using MAT. So about 23% of people exposed to opioids develop an opioid use disorder, second only to tobacco. So 23% of people exposed to opioids will develop issues with a use disorder, 32% with nicotine, compared to cocaine, alcohol, or cannabis. So knowing that we've had a large amount of opioid in our communities, 23% of that population are at risk for developing an opioid use disorder. And then you take into account things like genetic and psychosocial factors. And then we really see why this has become such a huge issue in our communities. So more than 1.2 million opioid prescriptions were written for 16 to 18-year-olds. And these were individuals who actually had pre-existing psychiatric problems, anxiety, mood, neurodevelopmental, non-opioid substance use issues. And not only that, but this group of people were more likely to be prescribed more than 90 days worth of medication. So we know the more the system is exposed to an agent, the more the system is going to want the agent. So 16 to 18-year-olds, we're talking a bunch of high school students here who've been given way more opioids than they ever needed. And then when you take another step back and look at the people who have been admitted to a substance use disorder treatment facility, so this could be they were admitted for alcohol or opioids or stimulants or whatever, they were admitted for substance use disorder. And these individuals were polled, and these were individuals aged 18 to 30 in 2011. This is the treatment episode data set from SAMHSA, and I think they kind of churned this data out. Like this is the most recent set. We don't have anything more recent than 2011. So it takes them a while to kind of churn through this data and spit out lovely graphs like this at us. But this is about initiation of use. So people who were admitted, so this isn't a whole population, but just the people who managed to get into a facility, the number of people who started substance use age 15 to 17 account for 34%. So if we're thinking about those 16 to 18-year-olds I was just telling you about in the last slide, like that's the age when people start their disorder. Like this is the root right here. So thinking about when this may happen and ways we can intervene to decrease the risk of this happening in our communities. Often by the time they're in their 20s and 30s, that's when we're admitting them to substance use disorder treatment. So dialing back and looking at what's happening prior to them presenting to us with an opioid use disorder, we all know we're talking about the tip of the iceberg from that last slide for those who end up in a substance use disorder treatment facility. And our liberal use of opioids is something we're all very well aware of. And you know, when you make changes yourself, you tend to think that others are making the same changes, but being aware that maybe not everyone is quite as speedy to make some of those recommended changes, or just we're also going to be dealing with a large number of people who are the sequelae of 10 years ago. They were 16 and being given, you know, 120 Percocets to take care of dental pain when they were 17. So the Robert Graham Center does a lot of good work in the shape of policy studies in family medicine and primary care. And off of that good work, they've come out with, I believe it was in a white paper from them, or a position statement. But the nation's growing opioid use disorder epidemic disproportionately impacts rural areas where physicians who can prescribe buprenorphine are scarcest. So thinking about where this is happening, when you look at not just the raw numbers, but per capita, it's in rural communities that we're seeing the biggest impact. And rural communities are consistently, historically, doesn't look like it's changing any day soon, understaffed when it comes to physicians. And then physicians who are actually going to prescribe buprenorphine, family medicine physicians. And so, yes, maybe that is my disclosure. I'm a bit biased for family medicine because that's my background, are the most likely to work in rural areas. So equipping our family medicine physicians, and quite honestly, all of our physicians, to have a knowledge of the risks of opioid prescribing, safe opioid prescribing, but then also identifying when someone has a substance use disorder and how to manage that substance use disorder so you can help people have access to treatment is incredibly important. So the available treatments for opioid use disorder, pharmacotherapy and behavioral therapies. So some would say you get just as good with one, you get just as good with the other. Maybe you should just go to AA or NA and hold hard to an abstinence only model. Truth of it is the gold standard is medication assisted treatment and some form of counseling. So they're getting medicinal support and counseling support. It is a road of change that is often fraught with many obstacles, and any and all the support they can get is required for someone to make those changes, stay with those changes, create a new normal for themselves. So gold standard is MAT, the pharmacotherapy being combined with some form of counseling or behavioral therapy. So part of that statement is informed by looking at studies where people have been able to maintain abstinence without the benefit of MAT, and it really doesn't work as well. So percent remaining abstinent over a number of months from a few different substances, because we do have medications to help with opioids such as heroin, alcohol, and nicotine. So MAT is not just an opioid use disorder term or way to think about it. And we have nicotine replacement, we have medications to help encourage abstinence and decrease in use of alcohol. So we have MAT for those other substance use disorders as well. And when we try and make those changes without MAT, it's hard. So you can see the drop off is fairly significant between the start and then at 3 months, and then it continues to slide in a downward fashion. So there was this lovely prescription opioid addiction treatment study, or POTS for short. 49.2% of POTS participants received some buprenorphine naloxone for about 12 weeks. They were abstinent at the end of that treatment period. Treatment period ended at 12 weeks. And then you saw the abstinence rate quickly collapse. So they had 49% who were abstinent, and then post-intervention, it went to 8.6% within 2 months. So after they came off meds, they're almost 50, went to just less than 10%. And then 18-month follow-up found many of those patients had actually gone back to receiving opioid agonist therapy, or MAT. And then the abstinence rate came back up and actually was a little bit better than with the original study of the 12-week treatment period. So studies like this and others are what demonstrate that actually being in treatment, receiving MAT, is very closely correlated to abstinence. So providing MAT, providing treatment for opioid use disorder, doing that gold standard combination of MAT plus your behavioral health interventions, it's good for our patients. Any opportunity for abstinence from illicit opiates and other substances is a good opportunity, and we need to help make that opportunity realizable for our patients. Harm reduction in relationships, employment, and legal consequences. So having someone engaged in MAT and therapy, they have an ability to engage in their relationships in a positive fashion, do some couples counseling if needed, family counseling. They're able to keep their jobs, able to keep their benefits, they can keep getting treatment. keeps them out of the legal system or decreases the level at which they're engaged with the legal system. Health needs decrease. They're not going to the ER as much, not needing to be admitted as much. They overall feel that they have a better quality of life. And buprenorphine in and of itself does provide more treatment flexibility and safety than some of the other methods like methadone or naltrexone. So that little asterisk on the other one, their trips to the ER and inpatient, there's this very necessary, needed movement within emergency departments to provide MAT in that setting. Because I'm having some screen difficulties anyway, I'm not going to do the jump out, jump back in and show you guys this website. But the website that's listed at the top from the American College of Emergency Physicians is an absolutely amazing guide for treating patients in the ER with opioid use disorder. So basically you have a patient who's presenting to the ER, maybe for some other reason, but while they're there, they happen to withdraw, or they show up because they're experiencing severe withdrawal. Maybe they're dehydrated, they've got vomiting that they can't stop, and so they've shown up in the ER. It is an opportunity to treat. It's an opportunity to take care of the vomiting. It's an opportunity to take care of the aches and pains, the agitation. It's an opportunity to rehydrate these individuals. And you can do that with traditional, normal means of providing antiemetics, IV fluids, some baclofen or ibuprofen, whatever, to take care of the specific complaints. But you can also provide them with buprenorphine, which will take care of all of the things that they're experiencing. It will pull them out of that withdrawal phase. It will satisfy those mu receptors that are vacant and making them sick. And you've got an opportunity to engage someone in treatment. So an X waiver is not required in order to administer or place an order for. You just need to have it on your hospital formulary available in your pharmacy, a dose of buprenorphine in the hospital or in the ED. So if you're in a hospital, you're a hospitalist, you're an ER provider, you can write an order for your patient to receive buprenorphine, and you do not need an X waiver. You can actually have a patient return to the emergency department for 3 days to provide them their buprenorphine dose, with the idea being that you're connecting them to services in a clinic that can continue that prescription, well, continue the medication by writing a prescription, because you cannot write a prescription from the ER if you do not have a buprenorphine, I'm sorry, it's not a buprenorphine waiver, it's an X waiver. If you do not have an X waiver, you cannot write a prescription. And that goes for being a hospitalist on the floor or any other provider in the hospital. You need an X waiver for the prescription, but you can provide that medication while the patient is in your care in the hospital. So that 3-day rule is actually part of the federal code of regulations, and that segment of that CFR is cited there. So a patient, you see them in the ER acutely, you provide them with some buprenorphine, start off with about 4 milligrams, see how they do. You can go up from there until their withdrawal symptoms are abated. And then you can tell them, come back tomorrow at, I don't know, 12 hours later, 24 hours later, come back at this time and I'll give you the dose that I gave you today, the total tomorrow. Just come back to my ER. It's an expensive way to do it, yes, but the fallout from not engaging people in treatment is far more expensive. But this is a way of very direct care for patients to receive MAT. So,
Dr. Troxler?
yeah.
This is Michael.
Uh-huh.
We ran into a situation a while back where one of our participants was admitted to the hospital. And the hospitalist or whoever the attending was would not prescribe the buprenorphine. I mean, basically, I think we were told that they didn't keep buprenorphine in their pharmacy.
Right.
And I was just wondering, for some of the smaller hospitals through rural areas, I mean, are there ways to help in coordinating or cooperation with that?
So yeah, the short answer is yes. And then figuring out the best route to do that, whether that means you find a champion within the hospital, because the hospital is going to have I can't remember, and I'm certain different hospitals call it different things, but there was a base at my old hospital, which was a small rural hospital, there was a pharmacy formulary team. So whenever we wanted to take a drug off a formulary, we wanted to add a drug to formulary, there was a an application process you went through, and then it went to the medical staff executive committee, and we discussed it and added it. And I requested that we add buprenorphine to the hospital formulary when I was in New Mexico, and we got it added. So if it's definitely not on the formulary, approaching the hospital, finding out what the process is to have it added to the formulary, but then also preparing your patients to, you never know when you might go to the hospital, right? So like, how do you prepare for that? But the ability to take your own meds in the hospital is a simple order. Patient is allowed to take home med, you name the medication, and you say how much of it is they're supposed to take when they're supposed to take. So that goes for any medication that is non-formulary in a hospital. So if they can have somebody run home and get it or whatever. I've also run into the situation where an OB patient post C-section, the OB hospitalist, the laborist, they call them, who was covering, didn't have an X waiver, doesn't matter. You're in a hospital, you can write it. She didn't feel comfortable. So my patient immediately post-op was offered Percocet, which was like her Achilles heel for her pain control. And it wasn't until the next day we were actually able to get her buprenorphine. And I even have privileges at the hospital she was at. Like, there wasn't even anything I could do. Like, the person in charge of her care was not gonna write it. So education is also part of our role in helping people understand, like, this, you're not a neurologist, but you're gonna keep them on their Depakote and their Keppra or their whatever. Like, maybe these are drugs you're not comfortable prescribing in the outside world. You're not going to manage these. This is the same kind of medicine. You're not going to stop your patient's seizure medicines because you're not a neurologist. You need to continue their MAT as well while they're in the hospital. So there's a role for education as well, and reaching out to your hospital and finding out where are the avenues to approach and provide the education. Because you get to know them, they get to know you, and then you can be a referral resource for them as well, because they know that you're diligent about doing your job the right way and you care about your patients. Most hospitals are probably not licensed to dispense it, so patients should not be sent home with take-home doses of buprenorphine. It was one of those lovely things we used to do from the ER. Like, you could dispense meds from the ER, and you could see someone for their urinary tract infection at 2 o'clock in the morning and send them home with their entire prescription of antibiotics. And we don't even do that anymore. So dispensing anything from the ER is just not what we do, and definitely not buprenorphine. Anybody who has a DEA can prescribe buprenorphine for pain management. It is not an X waiver required condition. The approved formulation for chronic pain is Butrans, which is a transdermal patch. And you do not need an X waiver to prescribe that formulation of buprenorphine. So it's kind of weird and conflicting. This kind you can do this with, that kind you have to be this way. Like, so it is confusing, and I think that's why our role is to provide education for those around us. But again, the website that's listed at the top of the slide, it has these beautiful like little drop downs that just walk you through when you've got a patient in the ER, what are you going to do with them? How are you going to decide this is an appropriate patient? How are you going to get them started? What happens if they're interested in the medicine and you give it to them and they actually get sicker? What do you do then? So it walks you through all those scenarios. It's a really lovely resource. And apparently, if you are a member of the ACEP, you can even get it on your phone as like a bedside tool. So you've got it right there. You don't have to be in front of a computer. I am not a member, so all I have is the website access. But it was, unless there's something additional bells and whistles on the app for your phone, I found it to be pretty thorough. So treatment retention for those who are using MAT, and then the benefits of MAT. You see decreased illicit opioid use when people are utilizing and have appropriate access to MAT. And then someone who is receiving MAT, their mortality risk actually starts to approach that of the general population as compared to those with an opioid use disorder who are not receiving treatment. So again, providing that pharmacotherapeutic support for our patients, as you can see, makes a big difference in their ability to move forward in their lives. So it's great that it's good for our patients. There are probably lots of things that are good for my patients that are really hard for me. because it takes a lot out of me. Like, they need their disability paperwork filled out. They need their FMLA forms filled out. That's good for them. It helps them keep their job and keep their pay. But they're really not fun forms for me to fill out. However, providing MAT is really good for providers. You can assess providers who are providing MAT, and will be an anecdotal case of that. It provides both short-term and long-term sense of satisfaction. You see patients get better, and you can see them get radically better from one visit to another visit. So it's kind of like, oh, I did something good. I think I might do that again. Someone pointed out to me, it's a little bit like a dopamine hit when you get to take care of patients and you see them doing well. And I'm like, oh, I hadn't thought of it that way before. But it totally is. You get kind of jazzed, you feel good. You're like, I'm ready to go to the next patient. I'm ready for the challenges that come at me because I feel good about the work that I'm doing. Also, because you've got a tool. Many times when people would come in and they would demand this opioid or that opioid, but they've got this pain and it's not addressed any other way. And so the so-called drug-seeking patients, which is not a term we should think about or use anymore, other in the context of using air quotes around it, because those are individuals who need help, whether it's in getting the prescription they're asking for, because probably they're going to get sick without it and they don't want to get sick. But maybe they also need opioid use disorder treatment as well. So when you have a patient in front of you who's doing the thing that they do to get what they need, you actually have an answer for them that's a better answer. And that's providing them with MAT. Ability to focus on the large issues that have a negative impact on the patient's global existence. Like, you can make that person's life so much better. They don't lose custody of their children. They don't lose their job. They actually have money in their pocket. They can buy the Valentine's Day gift for their girlfriend. They can buy a new pair of shoes, giving themselves pleasure and a sense of, I am worth something. The other thing is they say thank you. People don't say thank you for, gee whiz, I'm so glad my blood pressure is 120/80 today. Thank you for helping me do that. Like, I love that lisinopril. Thank you. No one has ever said that to me. But they do tell me thank you because they're getting their lives back. They feel stable. They feel normal. When I go in a room and I ask a patient, how are you doing? They're like, you know what? I feel normal. Then I know we're doing the job that we set out to do. We're doing good work. Good for the community. So people who are engaged in treatment, there's a lot of words on this slide, and I've already said a lot of words myself without reading off of slides. So this real quick, and you guys have access to this. Basically, incarcerated populations, a very large number of people in our prison system are there because of drug-related charges, activities. So if we actually get people into treatment and they no longer are engaging in the activities tied to their drug use patterns, then they aren't going to be in prison as much, which means they're going to be in our community, participating in the things they need to participate in, like raising their children, working a job, paying taxes, all of that kind of good stuff. Starting a pickup league for basketball for 40-year-old men. I don't know. They're going to be out in the community doing things that are positive for the community, and not having grandmothers and grandfathers raise children because parents are in jail. All right.
I got another question about that.
Yes.
Because I've had some interaction with law enforcement, and they tend to quote crime statistics and the diversion of buprenorphine. Over 50% of buprenorphine is diverted. It's the most commonly it's the most common drug into prisons and that sort of thing. I mean, quoting research articles and things like that, how do you suggest best approaching law enforcement in challenging some of those crime statistics?
So one of the things that's a little difficult to do, and it takes time in getting to know your patient, because one of the things I heard about this region when I first came here was buprenorphine is a lot of people's first opioid, which I found interesting. But I'll have to tell you, and granted, I've not seen hundreds and hundreds and hundreds of patients yet. I haven't been here long enough to have that kind of number under my belt. But when I talk to patients and I get their story, actually it's not. They were exposed to some other opioid before. and they're getting their buprenorphine in an illicit manner because there's value to it. You can take it and you won't be sick. You can take it when you can't get the other stuff, until you can get the other stuff, because the supply of Roxys and all the others are becoming more difficult. But people are going to misuse. They're going to misuse stuff, whether it's an opioid or something else. Like we don't think about somebody driving around with some gasoline in the back of their car as that's a substance they're going to go home and use. But it could be, because people do huff. And actually, the Appalachian population is one of the higher populations for using inhalants. So who's to say that that grocery bag full of spray cans is really because they're spray painting their son's wagon blue and gold? Maybe that's what it's going to be used for, but not everything. So they have a very different perspective than we do. And I also know that we have people who provide MAT for financial gain in our communities. That's the main reason some of the clinics we have are in existence, is because it's fast money in a legitimate, I have air quotes today, air quotes everywhere, in a legitimate means. So I think having the conversations about, comparing safety profile, like, can we look at how many overdoses we've had in our communities as we see buprenorphine being the more prevalent substance that's being, traded, sold, whatever. Because it's harder to overdose on buprenorphine. It's not impossible, but it's harder. It's real easy to overdose on fentanyl. So the fact that we have pharmaceutical companies, I don't think we have knockoff shit of buprenorphine floating out there. I hate when we get to that point, because then we will potentially have fentanyl laced in it. But there's that potential of, it is actually a safer, if you're gonna divert something, it's probably one of the safer agents to divert. Not that I want anybody to divert anything, but if you think about it from a harm reduction standpoint, but there are going to be people who do wrong stuff with it. There's going to be people who do wrong stuff with all kinds of substances, used in ways that we don't want them to use it. And that just speaks to, we need to do a better job educating our communities, all the individuals who come into contact with those from a substance use standpoint, whether that's medical, mental, law enforcement, schools, all of it. And that's why doing things like we're doing and having you guys participate in ECHO, and then going into your communities and providing this education to your communities is so important. So looking at it from other angles, Mike, is what I would suggest. Not necessarily pulling out the really boring and dry research articles. Sorry for all of those who love research articles. I don't really fall in that category. I like the boiled down version. Somebody digest it for me. But coming at it from a different angle and thinking about it in ways that may help them see another way of it. Sort of like from the ER, where you have, the frequent flyers, the rotating, like, oh, they're here again. Oh, they're here again. Well, let's do something different so that we can get them on a different path. And we'll see them, maybe the next time they come in is because they're bringing their kid in because they were doing something fun and awesome and somebody broke a leg or an arm. Like, typical things you see in the ER, and not this person coming in again because they're withdrawing, or they had an overdose, or they've got an abscess. Like, let's change our approach and the way we think about it so we can see a different outcome.
Can I say something quick?
Yes, Amy, please.
I actually have been doing research on that for RCORP, which is Rural Community Response Program here in Knoxville. And one of the things that, like, the jails they're the front lines. That in prisons, the front lines of people that are addicted. And it says that estimated 65% of all inmates in U.S. prisons suffer from substance use disorders, and 80% of all crimes in Tennessee are drug related. And there's been studies done in states where they implemented some kind of MAT program within their facility, their jail. But what they have found have been positive outcomes. I think it was the Sheriff Association. Oh gosh, I can't remember. But anyway, they had actually put a statement out too. But MAT in correctional facilities is proven to significantly reduce recidivism rates, increase workforce participation and employment, reduce overdoses, reduce financial costs to society, and increases rates of enrollment in treatment services after release post incarceration. That's when your overdose rate is like the highest. But yeah, and then also like what you had said about grandparents raising their grandchildren. You know, if someone's engaged in treatment, you know, most likely they're going to, you know, still have their kids with them. And I've been on both ends of the fence when it comes to taking it the right way and taking it the wrong way. But the one thing I do know is it kept me alive, you know, and it was definitely harm reduction at the time for me. But anyway, I just wanted to say that because it does have a lot of positive outcomes here with, you know, implementing MAT and judicial system.
Amy, what can you share what you have? Is that something you can post to the chat or you can send to Melissa so we all have access to it too? That would be interesting to see some Tennessee specific stats as well. That'd be great.
Yes, I will.
Cool. Thank you, Amy. Thank you very much. So really excellent points. So buprenorphine comes in a few different formulations. You can get a film, and Suboxone, Subsolv, and Bunavail are the film brand names. Subutex is buprenorphine as a mono product, so just buprenorphine, no naloxone, and then generic buprenorphine plus naloxone. And then there's the depot Sublocade and I'm going to say it wrong. Brixadi. I want to call it Bridaxi. It's not what it is. Read the word, not what I'm saying. So there's a few different ways to get it. There is also Probufene, which is an implant, like a rod in the upper extremity. I don't really know that people are using that very much at all. I think it has a 6-month release rate. The shot, the depot, the subcutaneous injection, Sublocade or Brixadi, that one's good for a month. You're doing that one about every 4 weeks. So buprenorphine is a partial mu opioid receptor agonist and has a weak kappa opioid receptor antagonist. So buprenorphine acts like a typical mu receptor agonist, like morphine or methadone. At higher doses, its impact on that receptor reaches a plateau. So lower doses, you tend to get more of that analgesic impact. And then higher doses, you get the craving impact. And then it just sort of taps out. As compared to full agonists like methadone, heroin, or morphine, you kind of cruise on into the euphoria and then respiratory depression, which is why overdose happens. And that's one of the issues with methadone, which is why buprenorphine falls onto the safer side, is because we don't go past the level of like what methadone does and getting us into a situation where we've got respiratory depression. Also at higher doses, the antagonistic effects of the kappa opioid receptor begin to come out. And that guy seems to play a role more in mood. So what's interesting with buprenorphine is it's an antagonist at the kappa opioid receptor. Full agonist opioids like methadone, heroin, morphine are agonists. There's too many agonist, antagonist words in what I'm saying, and I'm sorry. But basically, the effect of buprenorphine is opposite the full agonist opioids. So it acts against the kappa receptor, and you actually have improvement of mood, whereas the other opioids with their full agonist mechanism, they are depressants. So kappa gets turned on by the full opioid agonists, and it makes you feel bad, makes you feel sad, basically. And buprenorphine doesn't seem to have that and may actually do the opposite. So I don't know if there's anybody out there studying that, but I hope they are. Imagine they are. They need to be. And I'm waiting for the boil down punchline on what that actually looks like. It has a very slow dissociation curve from opioid receptors, which means that people can take it several times a day, up to 3 times a week. So you could have somebody totally on an every other day regimen that totally makes sense because it has this incredibly long half-life, and it's not going to vacate enough of those mu receptors for someone to really be like, oh, this is horrible and I'm in withdrawal. Physically, anyway, what it's doing on the receptors. But you can also dose it several times a day if you're trying to get the analgesic benefit out of it. And that is a key component to keep in mind if you've got a patient on buprenorphine for their MAT who are experiencing an acute pain issue or even chronic pain. You can manipulate this slow dissociation curve of the buprenorphine to your advantage in those situations. So this is just a pretty little graphic of what I was mentioning, the partial agonist activity of buprenorphine versus the full agonist of all the other opioids. And then our other MAT friend in the medicine cabinet, naltrexone, is an antagonist, so it's going to block that mu receptor, as does naloxone. Naloxone, though, we know we use in that rescue period and not as a long-term. Naltrexones are long-term non-opioid MAT. So following a sublingual administration, you get peak levels of your buprenorphine within 30 to 60 minutes. And then, like I said, the half-life is really long. So it takes like a day and a half almost for it to come out of your system, enough for anybody to be like, oh, I don't think I have as much on board. It may precipitate withdrawal if it is introduced into someone's body system prior to enough of the other full agonist opioid being present. So typically we start at 2 to 4 milligrams of buprenorphine, and then you can follow that 3 to 4 hours with an additional dose of 4 milligrams. You're gonna know, your patient is gonna know though, whether they're getting any benefit from it before that 3 to 4 hours, because by an hour they should have gotten the impact from it. So if at an hour they're still feeling just as sick as when they first took it or more sick, then your instructions to them may be like, go ahead and dose again. On the second day, what you do is you take that first day dose, total it up. So if they took 4 milligrams 3 times in that first 24 hours, the next 24 hours, they're going to take 12 milligrams as a single go. Stabilization ranging anywhere from 8 to 24 milligrams a day. I know that in Tennessee, we like to think 16 is the maximum. It's not. Pharmacologically speaking, 16 isn't where the end of the story happens. It can go higher than that, but that also is a whole different conversation with what's allowed by our insurance companies. So buprenorphine is a semi-synthetic analog of thebaine. So these are all morphine derivatives where this all comes from. Most buprenorphine is excreted through the biliary tract, but it does end up in the urine. So it's detectable on urine drug screens. You just got to get one that specifically tests for buprenorphine because you will not pick it up if your urine drug screen is only testing for opiates, because that's going to be your heroin, codeine, and morphine. So you need one specific for buprenorphine. Taking it sublingually, you get, and I've seen percentages all the way up to 50%, but most of the percentages I've seen are around 30%. If you take it sublingually, if you swallow it, you're getting less than 5. So talking to your patients about how they're using it is really important to make certain they're getting the most out of it. If they're injecting it, they get 100%. So if someone's injecting it, you want to know why they're injecting it. Because quite honestly, financially speaking, especially if someone's having to pay out of pocket for their buprenorphine, injecting it means that their 2 milligrams that they just injected, they got 100% of those 2 milligrams. Whereas compared to an 8 milligram, putting it sublingually one time, they're not. So it comes out to be an economic endeavor. However, there are some individuals, it's not even about what's in the syringe, it's about the relationship with the syringe. And as a treatment provider, you want to know those things about your patient because that's going to make a difference in your ability to properly address their experience and help them move from where they are to where they want to be. So high affinity, slow dissociation, which I mentioned already, from that mu receptor. This prevents withdrawal symptoms, it decreases their cravings, and other opioids just don't have the impact like they would because the buprenorphine is sitting there. So I'm taking all my buprenorphine, I'm taking it as prescribed, and I don't know, that gal came over and she had some of the Roxy, and it just, I'd had a bad day and it seemed like a good idea, and I took it, and nothing happened. I didn't feel it, didn't do what it normally does, and I just felt really bad because I did it. I'm really disappointed in myself. So that happens, and it's a huge learning moment for your patient because they're like, I got nothing out of it, and then I felt bad. Why am I going to do this again? So oftentimes they'll come into your office with stories like that, and it's our job to encourage them, like, you just learned a lot from that happening, because they're going to beat themselves up for having done what they had done. But it's a huge learning moment for them. So don't miss that opportunity to point out to them what they learned from that misstep. It's actually a building block and not a misstep, in my opinion. It's unlikely to block all effects from an opioid. So once somebody's stable on their buprenorphine, because it's a dynamic process, this binding and releasing off of the mu receptor, in those patients who have acute pain, like they've had some dental stuff or they're having surgery, you can actually use, which reminds me I need to call someone today. Sorry. I had a patient who had surgery yesterday and I need to talk to them and see how they're doing today, because we are using Percocet for any of that pain that's not managed by dividing their buprenorphine dose. So I'll divide the dose, but I will also use a full agonist, knowing that I've got some slip-in spaces that we can use a full agonist as needed to help control pain. So understanding pharmacologically how this medication, the pharmacokinetics, the pharmacodynamics of how it works, you can manipulate that to your patient's benefit. Dry mouth, nausea, vomiting, constipation, all the things that you can see whenever people have opioids, some of those side effects. The excessive sweating is an interesting one. I've had a number of patients who, before I realized that could be a side effect, like, I don't know what the deal is, but there's something wrong with me. A number of my women were like, maybe I'm going through the change. I'm sweating all the time. So just being aware of what potential side effects your patients may experience. A number of them can be addressed with a little bit of extra medication of the type to take care of, like chew some gum, use that dry mouth, swish and spit stuff, using antiemetics, Miralax, stimulant laxatives, ibuprofen for the headaches. Because most of the time with any of our pharmacotherapeutics, the side effects are transient. As long as you can get past them and it's not debilitating, you can get over them. But if they are debilitating and they are not passing, then we need to think of other ways. Some of my patients, one of them, like a specific generic, the Sundown, I can't remember the company, she can't have that generic. There's something in it, she just makes her sick. A different generic, she's totally fine with. One of my patients, I have her taking the strip for that reason, because of some inactive ingredient in the tablet makes her sick. So working with your patients, because it's not just about the buprenorphine or the naloxone in the tab, it is potentially some of the inert inactive ingredients that went together to make that substance for them to stick under their tongue. It is not associated with prolonged QT intervals and lower overdose risk than methadone. So again, safer than that MAT choice for a number of people. These are all the different formulation possibilities and the conversion. So I love this slide. I'm not going to talk about it. It's there for you guys to look at if you want, because these slides are available. But the conversion is important because 8 milligrams of Suboxone is not the same thing as 8.6 of Subzol. They're not the same. So being aware of that conversion is important. Advantages of buprenorphine, fully participate in treatment activities and other activities of daily living, so they can ease into transition into the normal environment. So it's not you taking them out of their world and doing all these great things and life is fabulous, and then you put them back in their same old environment and they have no tools to deal with that same old environment. They're in their same old environment and you're providing treatment interventions that help them manage that environment so much better. So they're not having to flip back and forth between these different worlds. They're able to make their world a better place instead of just being removed from that world and then put back in it. Limited potential for overdose. Minimal subjective effects like sedation. So the idea that someone getting methadone and driving, I know makes some people nervous. Buprenorphine and driving should not make us nervous. Anytime someone starts a new medication, you always want to make certain how it affects you before you start doing things like using jackhammers and such. But typically the sedation from buprenorphine, it's not there. A number of my patients actually report being activated. I may have shared this with you guys before. I have a PAD who's in New Mexico, a patient with cystic fibrosis, and he would end up in the hospital periodically for cystic fibrosis flares. And the doctor's there. Thankfully, it was on formulary. They did continue his buprenorphine, but they would always want to give it to him at night. He's like, I can't take this at night. They're like, but it's an opioid. It's going to make you sleepy. It's like, I'll be hanging from the ceiling if you give it to me at night. I need it in the morning. So finding out those kinds of things from your patients as well. And then enhances retention and treatment. So MAT, buprenorphine because of its ease of prescribing. It can be done in an office where they can potentially avoid some of the stigma because it doesn't say addiction over the front window. They're just going to their regular doc and getting this. So there are lots of reasons why buprenorphine is easier for our patients to engage with treatment using that medication. Reducing relapse rates, withdrawal, blocking the euphoric effect of other opioids, that in-office setting, it can be primary care, USA setting. It does discourage IV use when you've got that combo there, because the naloxone in the IV, you tend to get all the naloxone effect first, so you get really sick. And then for take-home dosing, so you were giving prescriptions, we're not having them come in and dose every single day and being watched. You can do that with it, but it's not a requirement. Disadvantages, medication costs. So if their insurance covers it, great. I've got some people with their Medicaid right now, I think they're paying like $1 to $2 for their buprenorphine. It's awesome. But without medication, they could be paying up to $400 a month. For those who are seeking to get out of the game of being physically dependent on a substance, buprenorphine may not be a choice for them. Naltrexone may be a better choice for them. You have to have a specific urine tox screen. Like I was mentioning before, it's not going to be picked up on an oxy or an opiate. If that's what you've got on your tox screen, it has to be specific for buprenorphine, just like you have to have a specific methadone if you're trying to pick that one up as well. And then, as you were talking before, Mike, that potential for diversion is definitely there. So knowing that MAT is just a piece of the pie, but without that piece, we don't have the whole pie. I don't know if you guys are like me. If I'm having pie, I'll take the whole thing. So parenting classes, substance use counseling, family counseling, job training, skills development, co-occurring diagnoses, like all of that, that all goes into that yummy, scrumptious pie we're trying to serve our patients. And so making that pie complete for them is important. And then all my references.